Hello, Dr. Priyanka. How are you? Good
Yes, I'm
evening.
doing well.
Okay, so in this mock test, so this is test, and it is not real, so it is mock, but it will be, we will just make it as real as possible. We will have one CCS with at least 5 or 6 VNet and 10 CBA together. So the CCS will be of at least 30 minutes duration, and 15 minutes will be given for CBA. All right, can we start?
Yes,
So
sure.
first, we will start CCS, the clinical case scenario. Okay, so this is the first VNet of this case.
Shall I speak up?
No need for reading aloud. Just assemble the information from this scenario, and then we will go ahead with the questions.
Yes, sir. Done. Right.
Done? All
Yes.
right, I will go ahead with the questions. We'll provide a list of 3 grading scales to categorize the severity of this patient's condition.
One is Hunton Hess grading scale and World Federation of Neurological scoring grade, WFNS, and um, grading the severity. Actually, the patient is having aneurysmal subarachnoid hemorrhage, most likely. So we can grade the severity as per the GCS, Glasgow Coma Scale, and also by World Federation Neurological scale, scoring, and also by Hunt and Hess scaling. So in WFNS, we look at the GCS. If GCS is more than 15, then the grade is 1. Grade 2, GCS is 13 to 15. Grade 3, 12, 6 to 12, and below that is the 4th grade. And Hunt and Hess grading will also we perform in similar fashion as per the severity of the aneurysmal bleed.
Oh, great. Next question. What are 2 immediate active issues in this patient warranting critical care referral?
2 immediate active issues. First is that GCS, the Glasgow Coma Scale, is deteriorating. The patient is drowsy, and second is that the blood pressure is is on a higher side, 180 by 110, as far as I remember. So these are the 2 critical issues which warrant, and also headache. So basically, these patients are at risk of rupture of the aneurysm. These are caused by spontaneous rupture of the berry aneurysms. So these are the basic issues which should be addressed while managing such patients. We should
Okay.
take care to prevent the rupture of the aneurysm, and blood pressure should be controlled. And like if the patient is having deteriorating GCS, then we should manage accordingly as per airway, breathing, and circulation. We should secure the airway, intubate if GCS is below 8, and manage the breathing and circulation as per as required.
All right. So 5 important initial investigations needed in this patient.
Sir, first I will go with the routine investigations like complete blood count, and I would also want a coagulation profile for this patient because important initial investigations. One should be definitely non-contrast CT scan in this patient, and second should be the routine blood investigations and blood investigation, coagulation profile, and
Yeah. Okay. I'm sorry, time is out for this particular question. What are 2 early complications that are expected in this case?
There are risk of vasospasm, rebleed, hydrocephalus, and delayed neurological ischemia in such patients. And patients can also, there could be seizures. So these complications, early complications, early are rebleed and raise ICP. That is what early complications.
Okay, very nice. So this has been it too.
So this is a CT scan showing aneurysmal bleed in the subfalcine area, and this is the DSA being performed, in which we can see this aneurysm.
Okay, no need to explain or read aloud. Just assemble the information from the information given over here, and then we will move to question. So once you are done, you just say yes, I'm done with the reading.
Yes, right.
Great. So list 4 early management strategies in this case.
Early management strategies. Uh, so what we usually do in aneurysmal bleed patients is either we can go for clipping or coiling of aneurysm. Okay, early management. So first, early management should be taking care of raise intracranial pressure, so which includes tight brain checklist. That is what we perform. The head end should be elevated 45 degrees, and there should be no tilting of the neck. ETCO2 should be kept between 35 to 40, and we should take care that the patient is not bucking and is adequately sedated. If required,
Mm.
we should go according to airway breathing circulation. If the patient's GCS is low, we should intubate and manage accordingly. Circulation and blood pressure should be taken care of. And ICP monitoring, if required, GCS is less than 8 and patient is showing abnormal posturing, then we need to take care of the ICP. And likewise, also we can, if the patient is having seizures, then seizures should be managed. And then we can proceed with clipping and coiling of aneurysm. And this is a small, this is an ACA aneurysm, 7 mm ACA aneurysm. This can be managed with coiling of the aneurysm. And the coil is usually placed in the DSA, and the coil basically clogs the aneurysm neck, and so it prevents the rupture of the aneurysm.
Yeah. So what are 2 important measures to prevent rebleeding?
Taking care of the raised intracranial pressure and controlling blood pressure, both. Basically, ICP depends, the intracranial pressure ICP depends on MAP and CVP both. So we should take care that CVP should not increase by tilting of neck and by coughing and bucking of the patient. And also we should take care that the mean arterial pressure should be kept in adequate range. 90 to 100, or it should not exceed above 100 in these patients, and that is what these important measures should be taken in such patients.
I'm sorry, what did you say about target blood pressure?
So target blood pressure, that I mean, the blood pressure should not be allowed to raise beyond 110, 100 to 110, because if the patient is
Okay.
having mean arterial pressure very high, then they could be rebleed of the aneurysm. So we should take care to control the blood pressure.
Okay. Okay. List 2 commonly used drugs to control the BP.
Commonly, we use labetalol, which is both acting on alpha and beta receptors, labetalol, and we can also use calcium channel blockers to control blood pressure.
Okay.
ACE inhibitors, angiotensin receptor blockers, they can also be used. But
All
we
right.
avoid NTG and cerebral vasodilators. Two
All
benefits
right.
of endovascular treatment in this case. Endovascular treatment will definitely be beneficial because it will be of benefit in those cases where the aneurysm is at the non-approachable areas, like in vertebrobasilar system, or
Mm.
the patient is elderly and obese and is having multiple comorbidities, and patient cannot undergo surgical exploration, so that in that cases the endovascular treatment will be highly useful.
Any other benefit?
When these aneurysms are at non-approachable locations like posterior circulation, like vertebrobasilar system, so that is the area where endovascular treatment is beneficial over um, this surgical
Nothing.
exploration. And
Yeah.
also, as per ISAT trial, we all know that it was a large trial performed in roughly above 2000 patients, and endovascular treatment was having survival benefit, and it also reduced morbidity in patients. Also, seizures were less, so that's why endovascular treatment is definitely beneficial over surgical treatment.
Okay, great. What are two main indications of surgery in case of SAH?
If there's a large aneurysm, uh, that where the neck of the aneurysm could not be coiled, so that is the time when we need a surgery in these patients. And also when there are mass effects because of hematoma present or maybe raised intracranial pressure, so that is the time when we need a surgery in these patients. Whenever intracranial pressures are high, surgery will be better than this endovascular treatment.
What are two main cardiovascular complications?
Sir, because in endovascular treatment, they give this so that's why there's a risk of thromboembolism of the foam which they inject in the endovascular. So there is a risk of emboli being going to other regions of the brain. So there could be a stroke, or there could be embolic complications. And also blood pressure, hypertension can also occur in these. And also ischemia can occur because of the emboli.
All right. So we need three. Just read and assimilate information. No need to read aloud.
We are trying to secure the aneurysm, but that is unsuccessful, and the patient is shifted to ICU without controlling the rupture. No, it means this intraoperative aneurysm rupture, significant bleeding has occurred.
Yes. Okay. Go ahead. Yeah. What are two preferred sedatives for use during mechanical ventilation in this case?
Two preferred sedatives for use during mechanical ventilation in this case. So the patient is bleeding, and also the patient is having raised intracranial pressure. But are the vitals stable, sir?
Yeah.
It's
What
not
is arrested?
vital stable. Then we can use propofol infusion maybe for sedating the patients, because it will reduce the intracranial pressure also. And if the vitals are stable, then propofol would be a great choice. And for sedation, like in my institute, I prefer fentanyl infusion. Uh,
Okay. Great. What are four immediate post-operative principles of management in SH in this case?
So the first important thing will be to control the raised intracranial pressure, which is quite evident because of the uncontrolled hematoma. So we should take care to manage the raised intracranial pressure, like extreme head tilt should be avoided, and patient should not be coughing and bucking. We should be adequately relaxed, paralyzed, and sedated, and also. um we should take care to prevent the this nimodipine is given 60 milligram 4 hourly in such patients for to I mean for as a cerebral dilator. And also we take care by giving hypervolemic hemodilution therapy, triple H therapy, though it is not very much preferred nowadays, but we should take care by increasing the volume and like we should give adequate volume, adequate volume of crystalloids in this patient so as to maintain a good volume. Because the
Okay.
cerebral blood flow will be dependent on that. And also, we should take care to reduce intracranial pressure, like using mannitol and 3% saline, which is the hypertonic saline. That will also act by increasing the cerebral blood flow. There have been studies which have shown improved outcomes with 3% hypertonic saline as compared to mannitol. So 3% saline should be preferred in these patients. And
Okay.
fever
I
and
think
all should be avoided because that will increase the cerebral metabolic rate. And which is already compromised because of the cerebral edema. So that's why we should take care of these things.
so what modalities of neuromonitoring you would employ in this case?
Sir, we can use ICP monitoring by putting the intracranial bolts pressure transducers. They can be placed in the extradural or subarachnoid space. And alternately, we can use the transcranial Doppler monitoring. We can also use Lindegaard index. If Lindegaard index is more than 3, then it implies SAH. So we should monitor neuromonitoring like with ICP, intracranial pressures, and using transcranial Doppler.
Any other monitoring, neuromonitoring device, clinical monitoring, clinical.
Clinical,
All right. Good. Identify two ICP reduction strategies for refractory intracranial hypertension.
sir, I've already listed the tight brain checklist. So we should be following that tight brain. You mean except that, uski baad, I mean, what after that? No.
Yeah.
After that, we should be using hypertonic saline or mannitol. And second, ICP reduction strategies.
And craniotomy is already done. Apart from that, and this is just for any refractory intracranial hypertension, not in this case. Okay. All right. No problem. I'm just going to a next scenario. After 24 hours of stabilizing BP and ICP, the patient successfully underwent endovascular coil embolization for the ruptured aneurysm. Post-procedure, the patient was monitored in neuro ICU and 6 hours later was extubated. This was 11. All right. How, how will you monitor cerebral vasospasm?
Cerebral vasospasm, we can monitor by using ICP monitoring, the intracranial bolt with that we can use. And also we can use this optic nerve sheath diameter like we use in our ICUs. If basically the optic nerve is a bulbous ending beyond the optic disc. So that is the most uh, when most sensitive part of the optic nerve to increase or swell in size when there is intracranial pressure. So if the optic nerve sheath diameter goes beyond 6 mm, so that is the time when the intracranial pressure it corroborates with rise in intracranial pressure beyond 20 millimeters of mercury. And we can also monitor cerebral vasospasm by I mean clinically we can clinically also, like if GCS is deteriorating, so that also points towards cerebral vasospasm. And also we can use transcranial Doppler. We can you look at the Lindegaard index if it is more than 3. In Lindegaard index, we take ratio of the middle cerebral artery velocity divided by the ICA, internal carotid artery velocity. I mean, if it is more than 3, then it implies cerebral vasospasm.
All right. What are two main predictors of delayed cerebral ischemia?
No idea, sir.
In general, okay, not pertaining to in this case, in any like general. What are three main drawbacks of hemodilution and hypervolemia that led to abandonment of triple H therapy in SAH?
There were reports of patients going into volume overload and increase. There were several reports of increased free radical mediated damage to the brain. So that's why this triple H therapy was now has now become obsolete.
Oh, so this is VNet 5. Initially stable, her condition worsened on post-op day 2. She experienced a decrease in her GCS to 7, U1, V2, M4. Trachea was reintubated and patient was moved to mechanical ventilator. A repeat CT scan revealed rebleeding and hydrocephalus. Nimodipine was continued and a transcranial Doppler was performed. An AVD was placed and levostam was administered for seizure prophylaxis. What are two main benefits of using TCD monitoring in this case?
It's a non-invasive technique of ICP monitoring, and also it's a very good guide towards cerebral vasospasm or any other occurring complication, because it helps us in knowing the blood flow velocities in middle cerebral, anterior cerebral, and the internal cerebral artery, internal carotid artery. So basically, it helps in distinguishing which is the cause of the bleed or stroke, or so that's why TCD is important.
Oh, what are two main complications of EVD placement in this case?
So first is obviously infection, because there's direct communication from the outside atmosphere, so that it can also lead to infection of the EVD. And second is it can lead to excess drainage of the CSF also, so that should also be monitored.
Yes. These three main risk factors of seizures in SH for which anti-seizure medication may be reasonable.
Risk factors of seizures in SAH. Cerebral edema, if there is increase in ICP because of intracranial pressure, because of subarachnoid hemorrhage, and excess presence of blood in the cerebral falx cerebri, so that can lead to seizures in SAH patients.
Okay. Patient's condition continued to deteriorate despite aggressive management in the neuro ICU. On post-op day 4, she developed worsening neurological status with GCS of 4T. Repeat CT scan showed a significant increase in the size of hematoma and further expansion of ventricles. She underwent urgent craniectomy, and intraoperative findings revealed extensive blood clots and severe cortical edema. Post-surgery, her GCS improved to 8 by 15 but low, prompting close monitoring in the neuro ICU. She was continued on supportive care measures, including hyperosmolar therapy with mannitol to manage her increased ICP. Despite these interventions, neurological examination remained concerning and she developed fever suggestive of possible infection. The team remained vigilant, collaborating with neurology and infectious disease specialists to optimize her care. The family was kept informed of her precarious situation as they grappled with the uncertainty surrounding her prognosis.
So just a moment,
Okay.
I read. So there is increase in size of hematoma and expansion of ventricles. So there is infection also. Fever and infection. Yes, sir.
Okay. No. What are four main causes of fever in this patient?
It could be infectious because the patient has undergone surgery previously also, now also. So it could be infectious. Second is it could be reactionary because of the it could be central fever also because there is raised ICP and other causes of fever.
Any other reason? All right. What are three risk factors for nosocomial meningitis?
Nosocomial meningitis. ICU stay beyond. No, sir, I don't know.
Particularly nosocomial, no?
Hmm. When
Or
there's hospital stay beyond 5 days, so that will be nosocomial. And plus, the patient has undergone several surgeries, so that will also give rise to nosocomial meningitis. And multiple surgeries because there are several manipulations, so that can always cause nosocomial meningitis. And
okay. What are three first line antibiotics for nosocomial meningitis?
Sir, we use third generation cephalosporins, vancomycin, and uh,
No problem. What factors predict a poor neurological outcome in SH?
in SH.
Yes.
A large aneurysmal bleed, low GCS, and
Okay, we are short of time now.
yes,
Sorry,
so
I have to skip. I have to just go through the last question. What are three main predictors of tracheostomy in cases of SH?
three main predictors of tracheostomy in cases of subarachnoid hemorrhage. Patients requiring a long-term intubation because of there's low GCS, consciousness, and raised intracranial pressures. So these patients will require prolonged mechanical ventilation and perhaps tracheostomy in SH patients.
Oh, okay. Thank you so much for attempting CCS. I will give you 2 minutes to relax. Okay, then we go to CTA. So, how was CCS?
Sir, very difficult questions. I didn't know.
When are you going to write part two?
Sir, actually, I'm not appearing now in like in the
May,
next month. Yeah,
maybe in May.
maybe might be because sir, slot is very difficult to get. I mean, last time I kept on waiting for the. I could not register for the exam only. So I
Right.
just wanted to be more accustomed with how the exam will be. So I just.
Okay, okay. So now you have an idea about how CCS will be
Yeah,
in real time. Okay. The rest of the thing, the feedback, I have noted down all the answers which were given by you uh, and the ideal, circumstances, what answers could be, what is expected from examiner point of view. So we will discuss all these things in the next session, day after tomorrow, maybe. Okay. Then I will just run the CPA now.
Next session will be on Saturday, sir, not tomorrow.
Day after tomorrow, I said. difficult. So now I know. Uh, all right. So CBA. So are you ready for CBA, doctor?
Yes, sir.
There we go. This is. I hope this is not tiring for you. Oh, okay. So there are 10 CBA, and I will start my timer now. Each CBA will be of 1 minute. Okay. So need not to read. Just answer the questions point wise. Be very specific. No need to explain. All right. This is the first question. Okay, doctor. What are the main steps of management?
So this appears like rhabdomyolysis to me, and for management of rhabdomyolysis, we do usually forced diuresis in these patients. We increase the intravascular volume input by increasing the balanced salt solution, the rate of balanced salt solution infusion in these patients, and followed by diuresis by giving the intravenous furosemide. And earlier they were studies supporting the use of alkalinizing the urine to enhance the excretion of myoglobin, but that is not recommended nowadays. So we only do forced diuresis in these patients. And three differentials could be uh, might be this is a
Yes.
construction laborer, so that could be, I mean, rhabdomyolysis could occur because of excessive strenuous work which he has done in the construction site, or it could be rhabdomyolysis could be because of dehydration, excess dehydration leading to muscle breakdown, and
Okay. Question. What is the finding here?
sir, there is an infarct mm, in the right occipital region of the brain. Perhaps this is hypoechoic infarct. And the next line of management.
Okay. Imaging. Any other imaging will perform to confirm your CT
What is the
findings.
finding? What is the next line of imaging we will perform?
Okay, we'll go to next. Sorry. Aesthetic.
MRI we can do, but
Okay, all right.
sir, sorry, I missed reading it.
You are reading MRI.
Yeah, just this is a case of central pontine myelinolysis, which is seen on the MRI picture. And the main risk factors for development is osmotic demyelination, which has occurred because overcorrection of early correction of rapidity of correction of hyponatremia. From 107 sodium has been increased to 141 so quickly, so that has led to a lot of osmotic shifts in the brain, perhaps leading to osmotic demyelination.
Okay. Any other risk factor? Normally, in any other condition, in general, not in this patient
Sorry,
for
you
this
are not
condition.
audible, sir. There was
I'm asking. You have said only one risk factor. I'm asking any other risk factor for the development of this question, this condition. Okay, no problem. So, next question. CT scan imaging. What is the diagnosis? Next
uh,
line of management.
right-sided subdural hemorrhage, and the next line of management should be evacuation, craniectomy and evacuation of the hematoma. And also we should reverse this because INR is high, and we should be using FFP and sorry, fresh frozen plasma, 10 to 15 mils per kg of fresh frozen plasma to reverse the coagulopathy. And we should drain this.
Oh,
This
coagulopathy reversal and neurosurgery. This is next question for you.
yes,
Okay.
hemianopsia. Can I see the question?
So,
Yes, sir.
so what is your finding here?
I can see hyperintensities in the occipital area of brain.
Yes.
Perhaps these are responsible for the optic changes hemianopsia, which is being seen. And next line of imaging will you perform?